Good morning, or good evening in India. This is Dr. Ramakrishna. I'd like to talk today about a major question that India faces as it moves forward in advanced cancer treatment. Is India ready for proton therapy? I'd like to start by noting that we are in a new era of cancer care. There have been fundamental advances in the way that we treat cancer. Principal to these advances are technologies such as immunotherapy, targeted therapy, personalized cancer therapy using genomics, proteomics, and other means of individualizing treatment, and advanced radiotherapy using technologies such as radiosurgery and proton therapy. Patients with cancer are now living longer with fewer side effects from treatment. We are in an era where it's important to rethink cancer outcomes. A new mindset for cancer care is needed. Patients are living longer, and in some cancer types, dramatically longer, and this progress has been made only in the last few years. The survival and quality of life of cancer patients has also improved substantially. And a fatalistic approach to cancer outcomes results in substandard care. So we must move forward and adapt to this new era in cancer medicine with a new outlook altogether. The innovations that I speak of, however, have come at an extreme cost. If we look, for instance, at immunotherapy treatments, in the USA, these cost between $50,000 to $500,000 a year, with targeted therapies typically also running in approximately the same range. So in the context of limited healthcare resources, how do we allocate care with these new modalities and determine a cost and benefit? Proton therapy is an extremely advanced form of radiation treatment, but there's a great deal of controversy surrounding it, mainly related to its cost. The facility cost for a proton center gives one reason to pause. A multi-room facility with 3 to 4 radiation vaults would cost between 120 to 250 million US dollars, and a single room facility would cost between 25 to 50 million US dollars. These numbers place the cost of a proton therapy facility at anywhere from 10 to 15 times the cost potentially of a conventional facility. The cost to patients for their treatment is proportionately high. The cost relative to conventional radiotherapy can be 6 to 20-fold, and the cost relative to IMRT, an advanced form of X-ray treatment, which stands for intensity modulated radiotherapy, can be 2 to 5 times as high. It costs approximately $100,000 per patient in the USA. But radiation treatment is extremely important to cancer outcomes. Nearly 2/3 of cancer patients receive radiation treatment during their illness, and approximately half of these patients are cured. And it has a long history, and our most important tool has been X-rays. We've made a lot of progress advancing the technology of X-ray treatment, which is a lower cost treatment than proton therapy and is used for the vast majority of patients. We use technologies such as intensity modulated radiotherapy, three-dimensional image guidance, and robotic positioning. And this type of equipment has become more widely available at leading cancer centers in India. But we've always wanted to see if there was a way to do better than X-rays, and we found that the way to do better than X-rays is to use an altogether different modality or a different type of radiation. And we've started to use more commonly proton treatment in the USA and in centers in Europe and other parts of Asia to try to achieve dose distributions which are simply not possible with X-rays. This is an example of a pediatric brain patient where we treated the cerebellum. And you can see with the proton treatment, the radiation dose is limited to the cerebellum with essentially no dose to the temporal lobes and to the orbits as compared to X-ray, even using IMRT, an advanced form of X-ray treatment. For prostate cancer, we can see that proton therapy results in much less dose to the bladder and to the rectum in comparison to IMRT treatment. And then in breast cancer, we can see that radiation treatment with X-rays results in a high dose to the heart and lungs, which can be avoided essentially completely using proton treatment. So protons are a form of radiation treatment. These are produced by what we call cyclotrons. They're positively charged particles. It's much more complex to produce protons than it is to produce X-rays or electrons, which are commonly used in clinical radiation oncology. But protons represent a fundamental advance in how well we can shape dose to tumors, and this has then the potential to dramatically reduce the side effects of tumors. Conventional radiation treatment is the least expensive form of radiation treatment, but has the greatest degree of dose spillage to unwanted areas. Intensity modulated radiotherapy is a more expensive form of X-ray treatment, but results in meaningful improvements in dose shaping. And proton treatment, the most expensive of all, has dramatically improved dose shaping. Protons are fundamentally different in the way that they deposit dose into tissue, and this is why they allow us to shape dose better than X-rays. William Henry Bragg described the dose deposition of protons in X-rays. And with X-rays, as an X-ray penetrates into a patient, it deposits dose very quickly and continues to deposit dose as it passes through the patient and will continue essentially through the patient. And so there's both an entry dose, a dose in the tumor, and an exit dose, if you will. With protons, on the other hand, the protons enter the patient, deposit a lower dose as they enter, but deposit the vast majority of their dose in a very sharp peak of energy, which can be calibrated to be at the depth of the tumor. And this allows for the very sharp dose distributions that we see, as once you pass through this peak, there's essentially no more radiation, as there are no more protons. We're able to deliver dose to the tumor, which is usually going to have a depth of many centimeters, by spreading out this Bragg peak of the protons by using a mixture of their energies. And using this technique, we can cover the tumor with dose, but then beyond the tumor have essentially no dose. And this is a great advantage over what we see with X-rays. This is another graphic illustration of the difference between X-ray treatment and proton treatment. One common form of pediatric brain and spine cancer is called medulloblastoma, and we have to treat the entire brain and spinal axis in that particular case for a curative treatment. In the era of X-rays, this would result in a great deal of unwanted dose to developing tissue in the thorax and abdomen. Using protons, we're able to deliver that dose with essentially no dose to the areas of developing tissue which do not require radiation treatment for this disease. So this benefit of protons is the result of their difference in dose deposition characteristics. So if protons are so much better, why don't we use them more frequently? And basically that relates to their cost and complexity. Proton treatment units until now have cost between $150 to $250 million and were extremely large, required large teams of physicists and engineers to operate. And so we're limited essentially to very large research settings at large academic large universities or research academies. The first proton treatments were in the 1950s, and through the 1970s, there were only 3 proton therapy centers in the United States and only 5 worldwide. But we've seen an increase in numbers over the last several decades. The complexity hindered and cost hindered adoption of proton therapy in the USA, and it was felt that there was a significant unmet need for protons. Using existing protocols, it was felt that protons would benefit greater than 250,000 patients per year. There are 1.4 million new cancer cases per year in the United States, of which 60% are treated with radiation. And of those treated with radiation, it was felt that about 30% were suitable for proton therapy, meaning that the unmet market demand in the US was felt to be extremely large. The current map of proton therapy centers in the USA reveals that there are 25 operating and 11 under development. In my state of Florida itself, there are 3 operating centers and 2 under development. There is certainly a rising cancer incidence in India, and the number of cases is predicted to nearly double by the year 2035. So there will be no shortage of suitable cases for treatment in India. Currently, there are 3 centers that are under development. These are multi-room centers based at Tata Memorial Hospital, Apollo Hospital, Mumbai, and the All India Institute of Medical Science. The population certainly could support many more proton centers, but are more centers justified on the basis of cost and benefit? When we adopted proton therapy, it became possible for our center to adopt it because of advances in technology which reduced the size, complexity, and cost of treatment, and allowed proton therapy to be delivered in a single room, which was not possible previously. We utilize a system called the Mevion S250, which is a single-room synchrocyclotron-based system. It was made possible through superconducting technology, which reduced the size of a synchrocyclotron from the very large units previously to one that was only 6 feet in diameter. In our center, the synchrocyclotron is suspended on a 3-story gantry, which rotates around the patient, and which, to the patient, however, looks very much like any other radiation treatment unit. We've reduced, the system reduces cost and complexity, but it's still a very complex and expensive device. This is the synchrocyclotron that I showed you mounted within the gantry of the proton therapy unit. It mates to this nozzle, which directs the proton beam to the patient, who's placed on this robotic couch. The nozzle can rotate around the patient, and the robotic couch can move in all directions to allow the beam to enter from the direction that's needed for treatment. The complexity of the system is much lower than previous systems, which has allowed a hospital such as ours to adopt the system. And this could be a solution also for intermediate-sized cancer centers in India as well. The patient experience is very streamlined, very similar to a standard radiation treatment, with the patient resting on a robotic couch. This is actually an image of the Proton Center at our facility, and it's housed inside this building. So the cases that are suitable for proton treatment are still being established. It's well established that proton therapy is of benefit for pediatric neoplasms, eye tumors, sarcomas, skull base, paraspinal, and certain brain tumors. But among common cancers, the data is still developing. We're seeking to determine whether or not proton treatment has substantial benefits for prostate cancer, lung cancer, breast and gastrointestinal cancer, and more common head and neck cancers. We've learned from our experiences with proton treatment that patients have less side effect as they're simply getting less dose. This is a comparison of a intensity modulated radiotherapy or IMRT X-ray plan for a left frontal brain tumor. And one can see that the radiation dose to areas of the brain that are not involved with the tumor is extremely high. This is reduced dramatically using only 3 proton beams. Another aspect of radiation treatment that isn't always discussed is that radiation treatment can cause secondary cancers. In other words, cancers that are the result of treatment, which may not occur until 5 or more years after treatment. And this is due to the fact that normal tissue surrounding the tumor is getting radiation dose in some cases that isn't necessary. In studies that have been performed looking at secondary cancer incidence, it appears that the use of protons can reduce secondary cancer incidence by a factor of up to 4-fold in comparison to X-ray treatment. In pediatric cancers, the case for proton therapy is very straightforward, as radiation treatment not only carries a high risk of secondary malignancies over the lifetime of the patient, but also can adversely affect developing tissue, such as bone growth plates or developing organs. The use of radiation treatment in pediatric patients is well established and essentially universally approved in the United States as an indication for treatment. This is another pediatric malignancy, Ewing sarcoma, and this is the proton plan, this is the X-ray plan, and this shows you a subtraction of the proton plan from the X-ray plan, and you can see the unnecessary dose to normal tissue diagrammed here. One of the staples of proton treatment in the United States with the increasing number of centers is for prostate cancer. And the rationale for using protons in this setting is to reduce the dose to rectal tissue and to the bladder utilizing protons. And this is achieved dosimetrically. This remains controversial, however, as it is unclear over the long term the clinical benefit of this dose reduction. But nevertheless, patients in the United States with prostate cancer do seek proton therapy, although the coverage by insurance varies considerably. Lung cancer is another area where there's a large theoretical benefit for proton therapy in select cases, as the use of protons allows a reduction of dose to uninvolved lung. Sometimes this reduction is such that without proton therapy, it would not be feasible to treat the lung cancer patient, particularly those who have tumors in critical locations, for example, next to the heart or great vessels, or with large volumes, which would result in large radiation doses to functioning uninvolved lung. Another consideration with treatment is dose to the esophagus, which can cause significant complications, both acute and long-term. In a study with, that was done with proton treatment at MD Anderson in Houston, they contrasted the rates of esophageal complications and also pneumonitis or lung complications utilizing protons versus either intensity modulated radiotherapy with X-rays or conventional radiation with X-rays, and found dramatically lower rates of esophageal side effects and pneumonitis or lung side effects. Another area of great interest, which is a very large patient population as well, is among breast cancer patients, particularly with left-sided breast cancers. It's well known that conventional radiation treatment results in a substantial dose of radiation to the heart, particularly for left-sided breast cancers. And this can result in an increased risk of coronary artery stenosis, secondary malignancies, and decreased lung function. The use of proton treatment can minimize and sometimes eliminate this excess dose. And we have good clinical evidence that suggests that this may be of considerable clinical benefit to the patients, as there's significant research which shows that this excess dose leads to coronary artery events. If one looks at patients with right-sided versus left-sided breast cancer, there's an excess incidence of myocardial infarction among patients with left-sided breast cancer who receive radiation treatment, consistent with the idea that this excess dose has a meaningful impact on long-term cardiac events. Other studies have shown that this increase in cardiac events can be related to the cardiac dose that's delivered by X-rays. And so an area of considerable interest now is the use of proton therapy for these left-sided breast cancers to reduce the long-term risks for heart attacks. Our Proton Center has been in operation now for 9 months, and our mix of cases is evolving as we treat more and more patients. But we have a large contingent of prostate patients. We also have a large contingent of brain tumor patients, pediatric patients, and lung patients. We've begun breast and gastrointestinal proton treatments and are entering patients onto clinical trials to understand the benefit to their outcomes. So the argument for proton therapy in India is based really on the clinical benefit of this treatment. It's of undeniable benefit for pediatric cancer and select tumors of the skull base, spine, eye, spinal cord. And there are more than enough patients with even just these indications available for supporting multiple centers in India. It also offers elective treatment for more common cancers for those who might travel internationally. And it's a notable technological achievement to make proton therapy operational. And it would be a great clinical achievement for India to have successful proton therapy programs. But the counterpoint is that this is an extremely expensive treatment for which there is limited clinical data to prove the benefit, especially for common cancers. And in the context of a healthcare system with limited resources, the cost-benefit ratio has to be taken into consideration as one plans out therapeutic strategies for a population, and as one makes decisions regarding the best investments in healthcare dollars. So there are many challenges ahead. This is still an expensive and restricted resource, and we're learning which patients benefit the most from treatment. There are major efforts underway for collaborative clinical research protocols among multiple proton institutions, and we've placed our patients onto clinical registry or clinical trials that allow us to track outcomes and show benefit to treatment. And this research is critical for the viability of proton treatment, which really depends on ultimately showing that there is a benefit for the great cost of the treatment. So I'd like to thank you, and at this point I'd like to take any questions.
So let's take the questions. The first question is from Ashish. In your estimate, how many patients would be traveling out of India for availing proton therapy?
Honestly, I'm not certain of the exact number of patients that are traveling out of India for proton therapy. it's not likely to be a large number at this time. If you look at because basically this is not going to generally be covered by any government funding, or this is basically privately funded. So certain countries that do send a lot of patients to the U.S. for treatment, such as England, Finland, Norway, these have government programs to actually pay for treatment. And so, for instance, pediatric patients will be sent from those countries to the U.S. Consistently for treatment. So I'm not sure of the medical tourism that's occurring from India.
Next question is from Dr. Akshay. What is the time taken to treat a patient using fixed gantry and rotating gantry?
So we don't use a rotational treatment technique for proton therapy, but fixed gantry treatment, I believe what he means are probably simple treatment where we're using one field per day like we use in prostate. Those take only about 15 minutes. When we use multiple fields, that increases the treatment time. And the typical brain treatment, for example, would take 25 to 30 minutes with 3 fields.
Next question is from Mr. Dayanand. What challenges will Indian hospital is likely to face in terms of cost-benefit ratio for Proton?
Yeah, the capital cost is extremely high, and the cost per patient is extremely high. So I think that even in the United States, it's a challenging proposition to have a successful proton therapy program. I think the key to success with a program is having an appropriate patient base, and this requires either a network of hospitals to support that patient base or a good location in an area where that's underserved. Of course, in India that won't be difficult, but the question is whether or not there'll be adequate amounts of patients who can afford the treatment. Because the cost is high, no matter how you try to reduce costs with this, it's still going to be quite a bit higher than IMRT. I think that Indian costs for IMRT treatment are quite a bit less than in the U.S., but on the other hand, they treat a large number of patients per day. With proton therapy, there's really a practical limit to how many patients you can treat per day because the machines require much more maintenance, much more downtime. And so typically you're not going to be able to treat, even in the best scenario, more than about 35, possibly 40 patients per day in a proton system, and that's with low complexity cases. With high complexity cases, you're probably limited to about 30 patients per day. So you have to factor that in when you think about recovering costs.
Next question is from Satya. Can proton beam therapy produce dose distribution comparable to Cyberknife or Gamma knife for small skull-based tumors?
Yeah, it's a great question. Proton beam radiosurgery is certainly something that is feasible, and it's especially feasible utilizing pencil beam scanning, which actually could potentially produce even better distributions. Now, there's going to be a limit to the size of tumors that you can treat on the low end. For instance, this will depend on the spot size of the particular system that you're using. But certainly for tumors that are on the order of 1.5 centimeters or greater in size, I think that especially using pencil beam scanning, you'll be able to produce better dose distributions.
Our next question is from Preeti. How does proton therapy work in relation to other mainstream radiation therapy and chemotherapy?
Well, it fits into the spectrum of treatments that are offered. It's used along with chemotherapy in the same way that conventional radiation would be. it really doesn't function in a different way than conventional radiation in that context.
Next question is from Dr. Akshay. On an average, how many fractions are required to treat a patient, say prostate or brain CA patient?
So for prostate patients here, we've been treating with 78 gray. So we're treating them with 39 fractions. For brain, of course, it varies considerably depending upon the type of tumor. For instance, with a skull base chordoma or chondrosarcoma, we may be treating with as high as 74 gray. On the other hand, with a meningioma, we may be treating with 54 gray. So the fraction number for the brain and skull base is going to vary typically between 25 all the way up to as much as 35, 30, 37 fractions.
The next question is from Satya. Can complex AVMs be taken in proton beam therapy?
Well, the history of proton therapy and actually AVM radiosurgery is that the Harvard cyclotron was one of the first applications of proton radiotherapy, actually radiosurgery for arteriovenous malformations with Raymond Gelberg. So there's a long history of using proton therapy for AVMs, and I think it's actually an ideal use of proton therapy radiosurgery. And it'll be even better utilizing pencil beam scanning because these are patients that should have normal lifespans if the AVM is obliterated, and reducing surrounding dose is of a great concern for those patients.
Next question is from Madhur. Proton's highly conformal dose distribution supports any dose escalation and therapeutic gain compared to photon treatments?
Yes, certainly. I think that there's a very great interest in dose escalation utilizing protons, especially at sites which are very difficult to dose escalate using X-ray treatment, such as pancreatic cancer. Also, there's a dose escalation protocol now for glioblastoma, which is sponsored by the RTOG, which we'll be enrolling in. And so I think that initially we're looking at verifying that the treatment is associated with less toxicity, but in some disease sites we've already taken the next step of going on towards dose escalation.
This question is from Dr. Ajay Rao. Which cancer sites have been recruited in phase 3 trials to test proton therapy in comparison to IMRT or VMAT for testing long-term outcomes between both?
Do you mean which disease sites or which cancer centers? I didn't follow the question.
Sir, he has not mentioned. Do you need me to repeat the question?
No, it's fine. I'll address both possibilities.
His recent comment is which disease sites?
Well, disease sites, yes, that makes that I understand. Yeah. It's very difficult to do a randomized trial for prostate cancer. I'm sorry, for proton therapy versus IMRT, and this is the reason why we've had difficulty in in convincing people of the benefit of proton therapy, because proton therapy existed, for 30, 40 years in the setting where it was only used for rare cancers. Now that we have quite a number of centers and people are getting treatment for common cancers, there's a lot of interest in doing randomization. And the sites where we're trying to get patients enrolled on such studies are breast and prostate. Those are the initial ones. Lung and pancreas are also following. So the RTOG, or NRG as we call it now, has opened trials in these areas. We're opening a breast cancer trial which will randomize patients. And there's also a prostate cancer trial in progress which we would have results from hopefully within the next several years.
Next question is from Mr. Vijay. Does proton therapy cost more than conventional forms of cancer treatment?
Proton therapy cause what? I'm sorry.
The question is,
Oh, cost. I'm sorry. Yes.
Yeah. Yes.
Yeah. Yes. It costs dramatically more than conventional radiation treatment. In the U.S., as I mentioned, on average, the cost differential for conventional treatment is something on the order of about sixfold. For IMRT treatment, the cost differential is about 2 to 4-fold.
Next question is from Rashmi. Why is proton therapy so limited in its availability?
Really, it's both cost and complexity. I mean, very few people are trained to use protons, so that's one barrier to entry. But I think more than that, it's just the cost. And but those barriers are becoming easier, I think, to breach now. With these compact proton systems, the entry price for proton therapy is certainly lower than it was.
Next question is from Satya. For commercial success of a proton beam therapy venture, do they need to have other machines also, like an high-end linear accelerator? He is referring to Indian scenario.
Yes, I think that's true in India. I think it's true here as well. I think that you could you could certainly have a standalone proton center, but the centers that have typically done well in the United States have been the ones that are based in a cancer center and which have the full complement of machines. I think protons will give a halo effect to any cancer center. They bring in more patients, and many of the patients don't need proton therapy that come to our center, for example, but they come because of protons. And then we treat them utilizing the best modality, which may be one of the advanced linear accelerators. So I think actually I would like to follow up with one more thing. I mean, one question that people often ask is, does the proton therapy just take away from then the treatments that are done on the advanced linear accelerator, and then reduce your patient population for that machine? And the answer is really, we haven't seen that effect. We've basically just seen that protons brings in more patients for protons, but also brings in more patients for the linear accelerators.
The next question is from Dr. Ajay. Hypofractionation valid in proton therapy too in sites like prostate and breast?
I think that there's interest in hypofractionation. Again, people are a bit cautious using hypofractionation in breast with protons. The skin dose with protons is higher in breast. That's one of the negative aspects of it. So there's more caution about doing that because with breast, you're quite concerned about that in terms of acute and long-term complications. With prostate cancer, there's certainly quite a bit of interest in hypofractionation.
Next question is from Vatyam. What are the side effects from proton therapy?
Well, it's really disease site dependent. And typically with proton therapy, you may use fewer beams than you do with IMRT. So you might end up losing some of your skin sparing benefits that are theoretically possible as a result of that. So sometimes skin dose will be higher. Another area that we are concerned with, of course, is the biological equivalence of dose, because protons are fundamentally different than X-rays. And one of the areas where there's uncertainty is regarding the biological equivalence at the distal end of the Bragg peak. We feel that there's some variability in the biological equivalence in that region. So we're very cautious with proton therapy when we're running the distal end of the Bragg peak right to a critical structure. So I think using proton therapy safely requires training and understanding of the radiobiology.
So we are taking our last question. What are the side, yeah, he has two questions. What are the side effects from proton therapy? And what kinds of tumors are best treated by proton therapy?
Yes, so I think side effects overlaps with the question that I just answered, and as I said before, skin dose is something that can sometimes be higher with proton therapy, but then the distal dose is almost always going to be lower, and so those side effects are reduced quite significantly. When we look at brain, for instance, we're able to reduce dose to uninvolved brain dramatically. This has short and long-term benefits for the patient. Basically, at every disease site, we're able to reduce low and intermediate dose dramatically compared to X-ray treatment. And some of the benefit of that is not seen as an acute effect, but we feel that it will be important in many disease sites as an intermediate or late effect, sparing basically in comparison to X-ray treatment. Regarding which disease sites are best for proton treatment, certainly the classic indications still have held up very well. Pediatric cancer, skull-based cancers such as chordomas, chondrosarcomas, certain eye tumors, for instance, are going to be treated extremely well. Certain spinal tumors, it's going to be critical. But I feel that in terms of the more common cancers, the ones that are going to have the most benefit from proton therapy are going to be left-sided breast cancers, certain thoracic malignancies, including certain lung cancers, favorable prognosis lung cancers, some head and neck cancers I think we can treat extremely well, and using pencil beam scanning I think it'll be even easier to treat complex head and neck cancers like nasopharyngeal cancers and have a lot of brain sparing. I think that pancreatic cancer with dose escalation is going to be a very interesting application. And I think some of the other gastrointestinal malignancies as well. So I think those are probably the leading areas for proton therapy, and that's a really large patient population.